Thank you very much. This was really a wonderful morning. We invite all the speakers to join us on the podium from the morning sessions as well. And till they come, so yes, we still, so for our panel discussion, please join us. Maybe it will be good to have a short synthesis of this morning. It was called Palliative Care for Everybody. Christina was naming it like spiritual care, so it seems that's where everybody, all of us can connect. We had Sister Monica at the beginning talking about palliative care as care at the border, and she was talking about borders in terms of culture, borders in terms of life and death, borders in terms of peace and struggle. And she was talking about love being the bridge that was crossing this border, and the person that is offering that bridge, that love, as the gospel, the living gospel for the others. We had Professor, do we have him here? Hatigetchi. Okay, he will come. We saw him, but he was talking about the beliefs, laws, and facts from the Islamic perspectives, but also about challenges for things that we feel they are basic, like challenges for doing good pain control using opioids. We had Dr. Vishnati from India talking about the journey of the patients as a transition and being together with those patients in the transition. She was talking about balance and hope and using rituals and community and the care offered by the team for achieving those, but also talking about her personal journey and the learning, incredible learning from patients and families. We had Dr. Kinsbrunner. He was challenging us to think about dying well, not good death, and also giving us a good view on rituals during the bereavement time, but also perspectives, Hebrew perspectives in terms of pain management, acceptability for using opioids, and do not resuscitate. And do not resuscitate meaning not meaning do not treat, and I think this is important to stress for our patients. Of course, Professor Anne van den Hoek, she was advocating for the chaplains. She was advocating through her experience, through her person, through research, through everything, showing us how important this is. But she was also talking about powerlessness as a space for meeting and connecting, and also something which we talk sometimes about kenosis. We have to empty ourselves in order to permit the other one to enter. And about the transition of hope which is disease-related, but maybe then moving towards transcendental hope. Ending with Professor Puchalski, who brought spirituality as a task for everybody. So everybody needs to do it, at least as a general level. So if we don't understand it, then don't do it after this conference. Sorry, we lost the message. But then also understanding complex cases and referring it to our colleagues. So as with everything, there is some horizontal competencies, but also some deeper needs for support from our colleagues. And it was very interesting to see, in order to, and that links somehow with the session yesterday, in order to be there, we have, even for spirituality, to get the medical language. We have to talk about definition, we have to talk about algorithm, we have to talk about diagnosis, we have to talk about research so that we are acceptable for the others. And somehow you very nicely closed the circle, because you ended your presentation with the quote from Mother Teresa, coming back to love. So you started, Sister Monica, with love as the bridge, and you said the love is the only cure for loneliness, despair, and hopelessness. So I think this is a wonderful message from the morning. And then the very impressive charter which was advocating for children and elder people. So thank you very much to all the speakers. And before we start the questions, I think we can have a big clap for all the nice work you did presenting it.
Thank you very much. Now is the question time. We have many questions. I think it will be impossible to answer all the questions. I begin with the general question to all the speakers. And the first one is about palliative sedation. I think it means a deep and continuous sedation, which is the position of the different religion about this issue. Then if you can give us a very short answer.
In terms of palliative sedation, I think in Judaism, I think it would all depend on the reason. I think that would be for example, if somebody's having pain and the pain is so severe that the only way to control it would be to put the patient, to sedate the patient, then I think it would be clearly acceptable to do that because you're treating the pain specifically. I think where it gets tricky, I think the same place it gets tricky in the secular world is when you're dealing with it for more emotional, psychosocial, spiritual issues where the suffering is not as tangible. And then I think it becomes more of a challenge. And I think, again, it would have to be looked at on a case-by-case basis. I think there would also be issues then around, for example, would you still have to feed the patient? Because I know that sometimes comes up even on a secular level, but I think in Judaism it would really be an issue because if you didn't feed the patient, there might be some would argue that the patient is dying of malnutrition as opposed to dying from the natural illness, and it might then warrant continue to feed the patient. But again, I think we look at those on a case-by-case basis.
Maybe Professor Atigic?
Ma la risposta è molto semplice. Se viene accettata, se non viene in qualche modo identificata con un qualche intervento eutanasico. Dunque è un po' come dire il gatto che si morde la coda, perché tutto dipende dalla definizione che si dà di eutanasia.
There's one, oh my God, oh, I'm sorry. This is that. I think I'd better stand, that's okay. Sorry. There's one question which asks me, when do you talk about acceptance? What do you mean? Does the patient accept to die? What is the meaning of acceptance in your culture about having a terminal condition? I think the answer to this would be that this does not happen overnight. It is a process of transition. And as the patient starts accepting that now these are the goals of care, initially they would start with, do anything but cure me. Then once treatment options go down, then they would say, okay, at least take away the symptoms. And towards the end, at least let me be able to walk to the bathroom. So this is how goals transition. So when we say acceptance of death, it does not happen overnight. And there are times when the patient understands that now I'm unable to get up. I'm unable to do what I was doing. So that little bit of aggression and the conversation goes down, and they start asking us questions like, will there be pain? Will you take away the pain? So that is when we realize that they are transitioning. So acceptance of death is not a one-time thing. It happens gradually. That's what we see. And then they start explaining, oh, this was my karma. Maybe something else will happen. So when they say those words, we know that slowly acceptance is setting in. And the caregivers also, right from the body language to the way they talk to us, the way they interact, everything starts transitioning. And that is why I think the integration of palliative care early is very beneficial. These things cannot happen overnight. So I hope that could be an answer to the question.
I have another general question. The question is, will the approach and the rituals be different if the patient is a baby or child? Who want to? And rituals be different if the patient is a baby?
Of course, rituals are different for children than for adults. I think that you involve the people who are there, the loved ones, but the focus of the ritual is the person who is sick. When it's a child, you use another language, you use other symbols than when it's an adult. I think that's very normal, and logically you cannot take, at least I think you cannot take one ritual that is the same for everyone. You can have the same words in a ritual, but you can adjust the context and you can adjust the symbols and the metaphors you use. It's another level of communicating. You communicate differently with people in several stages of life, well, also with children.
The microphone is here.
I think, again, in terms of children, and I'm not sure, are we talking about rituals for the children or rituals?
Yes.
Yeah, for the
Yes, when the child dies.
I mean, the rituals for children in Judaism are pretty much the same as for adults in terms of, the way they're handled. There's something, I mean, obviously, it's difficult if you're dealing with children who lose a parent, for example. So you have young children who might lose a young parent. If they're below the age of 13 for a boy and 12 for a girl, then they're obviously not obligated to go through the shiver, the mourning rituals the same way as an adult would from a Jewish perspective. But I think that in terms of the children themselves, if the children is the one who's dying, those rituals are pretty much the same, only with the exception of a baby who dies within the first 30 days of life. Then they're handled in a somewhat different way.
La mia esperienza è solo in ambito pediatrico. I bambini sono una persona in continua formazione, per cui logicamente le modalità di approccio sono diverse. Nel neonato e nel bambino nei primi 3 anni l'approccio è focalizzato su una comunicazione di tipo gestuale. Nell'età successiva la comunicazione diventa anche verbale, perché completamente diversa è anche la percezione della morte nelle varie età, e quindi sapendo che i bambini hanno una percezione della morte diverso è l'approccio, molto più focalizzato sulla gestualità, sulla comunicazione non verbale nelle prime fasi della vita, mentre diventa assolutamente concreto, onesto, ma sempre pieno di speranze nell'età successiva.
Another general question I try to answer is, what is terminal sedation and what palliative sedation? And we prefer to speak about palliative sedation and not terminal sedation, because the sedation, if palliative care doesn't cause the death, then all the documents all over the world now are the title of palliative sedation is much, much better. Yes.
So just related, there was a question about somewhat of the same topic. It is admirable that chaplains are welcome on the team for end-of-life discussions with patients facing critical decisions, but do we not have a duty to speak out when life is being hastened unnecessarily by drugs that make for terminal sedation? And then some issues about boundaries and medication. So I think this has already been said, that that this is not done frequently, that there's a lot of discernment as to when to do palliative sedation, which is the better term. I think in terms of, and I'm not sure if this was a chaplain or who asked this question, but we all have a duty, if we have an ethical concern about something, we have a duty to speak out about it. But before that, we need to check with members on the team to see that, is it indeed unnecessary or not? Appropriate palliative care, the members of the team do prescribe medications judiciously. They think about it, the doses are appropriate, nobody is trying to hasten death. And one of the earlier speakers did talk about, a bit of the double effect concept. But I think I have had consults from family members where they felt that their parent, for example, was being over-sedated with medication, pain medication, and that this is not what the family would want. And as a consultant coming in, trying to find out what was the reason for the medication and why did the family feel this way. And usually it ends up being that it was appropriate, and working with the family is important. But there have been some cases where everybody has a different perspective of how to identify pain, or in patients who can't speak about the pain. So thinking that someone is wrinkling their forehead is in pain, whereas the family member says that person's always been like that. Those are issues, yes, that we have to go into deeply. So I would say to this question, if you have a concern, talk to the clinicians on the team, ask them what the reason is, tell them your concern before you go to the patient and the family, because in general, good palliative care addresses these issues appropriately.
I ask the speakers if they have a particular question to answer.
Yes, I received a question about how practically we approach the family or the trustee person of a palliative patient who wants to absolutely prolong life, whatever the situation of the patient is. And in brackets it was said to think of a Christian patient. So this is a very, very difficult.
Another question is the same for all speakers, then you can answer. Thank you.
Okay, so it's a very difficult question, because here really comes in my conviction, our conviction of palliative care as a way to live at the end of life, facing somebody who doesn't share this view at all. And on one hand, I'm called to respect everybody's desires and way of life. On the other hand, I also have my convictions. And in this question, it's the most powerful that these two things meet. And I had once a patient who told me, Monica, I want you to know when I won't be able to speak, I want you to do everything you can that I live as long as possible. And I asked this patient, can you explain me why you want this? And he said, yes, I'm the last one of my family who survived the Shoah, the Holocaust. It's my duty to live. And when I heard him say this, and I could understand why this is in his plan of life, I said, yes, I will help you. This doesn't mean not to give palliative care, because palliative care doesn't shorten life, but I have to respect his aim of life. Now, in practice, when I meet families, I think the first thing is really to listen well why somebody says this. What is behind it? If it is really that he knows that his family member who now cannot speak for himself wants this, it's another case than if it's a family who doesn't want to take any decisions and who feels very burdened by decisions to take. And very often there it's already enough to say, we ask you all these questions because you are the one who knows your loved one most. Especially somebody in coma, I only know him in coma. I cannot ask him questions, but you know him, you are his mouse. What would he have wanted? It's not that we want you to decide. We want you to speak for him. Then sometimes also can come in really some information giving about the religion, to say, I'm also a religious person. I understand our religion like this, or I know about your religion, I understand it like this. This can also help, and if it's all these discussions, we don't come really to a common way, then sometimes I think I just have to leave this question and try to change the question and to see what in this conflict, in this framework we can do and how we can give best palliative care and already go this piece of way together. And then, if it comes really to the extreme, resuscitate or do not resuscitate, I have to respect the family. At least in the framework of Israeli law, where I live, whatever religion a patient has, I have to respect the family. But many, many times, really to give good palliative care and to help the person not to be suffering and the family to live quality time puts then a bit away this question and allows us just the same to care well for the patient.
All right, I have some questions. How much do you tell about the patient's story to the whole team in order not to break confidentiality? Maybe I'll give a short example. As a chaplain, I was once visiting a young man who was dying of cancer and who trusted to me that he was in fact gay. He never told his mom, he didn't have a dad. And he was an only son, and his mother was still hoping that he would marry and give her grandchildren. So when he was dying, that perspective was not possible anymore. And when I visited him one time when his mother was there, I sat next to him and he took my hand and he told his mom, listen, if I would not have been dying, I would have asked Anne to marry me. It was not easy for me, but you could see the mom's face lit up, literally lit up, and a smile of joy came on her face. And when she left the room, I told him, why did you do that? And he said, because it's no longer about me. I'm going to die, but she has to live on, and I wanted to give her something so she could live on. I'm not going to say that to the healthcare team. This is something between me, the mom, and the patient. What I did say was that I helped or support them in grieving and in saying their goodbyes and in supporting each other for what was going to happen. But they didn't need to know, the team doesn't need to know what really happened there, because there is a difference between need to know and nice to know. And I'm sure a lot of colleagues would have liked to know what was happening there, but they didn't need to know. There are two questions who are a bit similar and who also were answered already partly by Sir Monica. Have you ever proposed any patient the gospel of Christ if it didn't find meaning in life? Or can a priest accompany, give spiritual care without proposing the gospel? And can a chaplain help a patient that is not Catholic? How? These are questions that are a little bit in the same way of, when I teach my students about spiritual care and I look at the Catholic tradition, the Christian tradition, then I can make a distinction between the charismatic model around World War I, where the priest would go in and say, this is the gospel, convert or repent, and you'll be back with God. The therapeutical model after World War II, which was all about empathy and listening and not talking about theology, but being more of a psychologist. And then came the hermeneutical model, and I prefer this model. It is when you feel a connection with the patient and an openness to share, you share. But if this connection is not there, you don't share. In a sense that I like to think that chaplains are living their tradition. I'm living the gospel in regards to patients. And if patients ask the question, why are you doing this? From what do you live? Then I talk about the gospel, but the gospel is not in front of me, in a sense, is in between me and the patient. It is part of my heart, and when patients want to look into my heart, they can, but I'm not being a missionary in spiritual care. One quick question, which I don't know if I understand it very well, but can we ask your opinion on end-of-life visions and dreams and non-medical ways of dealing with this patient's experience, and when they should be medicated? Are we interfering then with allowing the dying to find peace? Well, it's my opinion that morphine and the like is not a solution to every problem or every experience the patients have. In a sense that if someone is not at ease because he or she is seeing things or experience things or dreaming things that have to do with the end of life, then communicating about it and giving it a place in spiritual care, in palliative care, is the way to go instead of treating it with medicines, I think. But people don't have to have negative dreams or visions. They can have very positive dreams or visions, seeing their mom in the room or having dreams about God or angels or whatever. I think imagination has a very important place in spiritual care and in theology. It should have, and it has. And I think this is an important part of spiritual care, working with the imagination of people, how they look at God, how they suppose God is like, how they suppose afterlife is like. Even if these images and fears give the patient spiritual care, medicines is not the first answer, in my opinion.
Thank you. Now, Professor Tigeci.
Ho ricevuto parecchie domande, ovviamente non posso rispondere a tutte perché, come già indicato precedentemente, richiederebbero risposte lunghissime. Tuttavia c'è la classica richiesta di qual è l'atteggiamento dell'Islam sull'eutanasia e se ci sono delle eccezioni in materia. Ricordo che in sede di principio, come già detto, l'eutanasia attiva e volontaria è rifiutata da tutti. Nei casi però clinici specifici la situazione cambia per una infinita serie di ragioni. Almeno 3 motivazioni però andrebbero dette. Nella letteratura nei paesi musulmani c'è un uso molto accentuato dei termini futile e non necessario per far nel ricorso agli interventi in terapia intensiva. È proprio questa indeterminatezza dei 2 termini che dà luogo a una possibilità di giocare e a una certa libertà negli interventi dei sanitari oppure nelle richieste dei pazienti. Il secondo problema riguarda il giudizio da dare sulla idratazione e nutrizione artificiale, su cui nei documenti giuridico-religiosi e anche delle grandi accademie giuridico-religiose islamiche non c'è una totale unanimità. C'è però uno slittamento che si sta verificando col passare degli anni da un atteggiamento, come dire, più soft a quello più, come dire, in linea con quello tradizionalmente sostenuto dalla Chiesa Cattolica, cioè nutrizione e idratazione artificiale non sono delle terapie, ma sono degli, come dire, elementi naturali da dare comunque al paziente in stato gravissimo o morente, indipendentemente da altre considerazioni. Va da sé, ve lo dico subito, che in mancanza di un'autorità giuridica e religiosa suprema e in mancanza di un magistero con una varietà di stati così elevata, di situazioni estremamente modificabili, ci sono anche altre opinioni. terzo problema che ricordo è che in Occidente tutto il dibattito sull'eutanasia si basa su due poli. Uno, l'autonomia più o meno assoluta del malato cittadino. L'altro, il dovere di non uccidere. Bene, in Occidente sempre più spesso il primo dei due poli tende ad avere la prevalenza sul secondo, per tantissime ragioni culturali, storiche e via dicendo. In molti contesti tradizionali, tra cui quello islamico, invece, la prima posizione è quasi sempre subordinata alla seconda, cioè il non uccidere rimane prevalente rispetto ai desideri del primo. Ancora di più? Il secondo quesito che mi è stato posto, molto interessante, è quello che riguarda il generale rifiuto della comunicazione della diagnosi a un terminale o a un paziente molto grave. Il problema non è di per sé islamico, ovviamente, è una posizione tradizionale di gran parte dell'umanità. Per centinaia di migliaia di anni non c'erano cure per curare assolutamente niente. L'unica cura vera che poteva esistere, anche se poco efficace, era la tutela psicologica, la blindatura psicologica del malato. Gli si mentiva per tirarlo avanti il più possibile o per consolarlo il più possibile. Questo retaggio è rimasto vivo ed è istintivo far ricorso a questo retaggio, piaccia o non piaccia, anche quando hai gli strumenti per agire. Questa situazione o questo meccanismo è molto comune anche negli ospedali turchi, negli ospedali iraniani e via dicendo. Non è, ripeto, una novità, non è un'offesa al paziente che muore, almeno non lo era per centinaia di migliaia di anni. Il problema si pone oggi in un contesto che si è rivoluzionato in pochi decenni e per cui atteggiamenti di autodifesa naturali, spontanei e validissimi rischiano di essere, come si suol dire, criticati. Ricordo un altro fatto, che in famiglie tradizionali e in famiglie larghe la malattia di un membro non è solo la malattia di quel membro, è la malattia di tutta la famiglia. Ciò dà luogo poi a un gioco di ping pong, di responsabilità, di coperture, di attenuanti, di scusanti, per dire e non dire. E ovviamente molto spesso gli ospedali accettano questo meccanismo. Io ricordo che il Shariati di Teheran, l'istituto oncologico ad esempio, sceglie, proprio per evitare questi parlamenti tra parenti in cui tutti dicono il contrario di tutto, un solo rappresentante della famiglia a cui dire la verità. Poi sarà lui a decidere se dire o non dire la verità al paziente nelle modalità da lui scelte. Non è un problema da poco, perché ha tanti risvolti questo atteggiamento, non ultimo quello dei trapianti d'organo. Chi sceglie la stessa logica familiarista poi finisce per incidere anche sui meccanismi di scelta di come dare, accettare o promuovere la donazione di organi. Il bambino ha un incidente di moto, finisce in determinate condizioni in rianimazione, si tratta o muore, sta morendo, l'equipe chiede ai parenti: date l'organo, il bambino può cedere gli organi o no? Che cosa si fa? Quando hai una famiglia larga non puoi consultare in pochi istanti, in pochi minuti, un Parlamento democratico dove tutti decidono il contrario di tutto. Bisogna decidere al secondo, in pochi minuti, sì o no. Ecco perché parecchi paesi islamici, musulmani, hanno poi varato in margine alle normative e le guide di condotta, le guidelines sui trapianti d'organo, anche delle postille con l'ordine dei parenti consultabile e l'ordine di importanza del giudizio dei parenti in merito.
Okay, I think we can end with Christina Puchinski.
Okay. So I have a couple questions I'm going to combine into a quick answer here, and it has to do a little bit with process. So one is what is the most effective way to integrate spiritual care in medicine in cases where lack of time and expertise is cited as the reason for not providing spiritual care? So I work in a busy practice. I don't have hours and hours of time with patients. I can speak to this from a personal and professional perspective. In anything that we do as clinicians, we have to use the time to assess what is the most critical issue, and that's the way that we function in our clinical settings. And if spiritual distress and suffering is the critical issue, we need to make time for that and adjust our clinical visit to focus on that. And so if we need to do the history. The history doesn't take a long time. It can be a minute or less, but if we uncover distress, then we change that visit to focus on that. We hopefully, when you have a chaplain in the outpatient setting, you can refer to that chaplain right away, but if not, we need to spend the time to address that and perhaps bring the patient back for a follow-up to deal with some of the other issues. So lack of time, we can work around that. What happens if you don't address that spiritual distress or suffering? That patient will go to emergency rooms and other settings to try to get that addressed. So it's imperative we do that. As far as training, this is the reason for developing this online course as a level 1 training. There are other trainings, there are ways, this is becoming more popular. There are trainings in medical and nursing schools as well. So there are resources for that. A related question is who on the team should diagnose spiritual distress? Again, in a generalist specialist model, all of us should diagnose, but we can think of it as a rule-out diagnosis. So just like with anything else that we do, we diagnose, we confirm if we're right or not, we talk to our colleagues, we refer to specialists, and that's the way that works. I don't have time to go into that in greater depth, but I can at the break if people are interested. And finally, the very important question of how to manage hope in a person who is going to die. And this gets back to what we heard yesterday about hope for a cure. And so it's not that we can fix and assign a hope, but through the process of dialogue to help that patient look at other sources of hope. People continue to have hope even if it's not for a cure. We can't reframe that for them right away. That does take time. But to offer up some reflective questions to have people think about other sources of hope.
Thank you very much to all our speakers, to all of you, and this is the end of this session, and thank you.